Gastroesophageal reflux disease, abbreviated as GERD. Gastro means stomach, and esophageal means esophagus, which is the tube connecting your mouth to your stomach. Reflux means that the food in your stomach re-enters into the esophagus. This is not how it is supposed to be. Food should move from your mouth to your stomach and not in the opposite direction. That is called vomiting. Why is this happening? The most common reason is because the sphincter between your esophagus and the stomach is not closing as it should. If that sphincter would close, then the food would simply not enter the esophagus. Now that the food enters the esophagus, it damages the walls of the esophagus. Why? Because the stomach content is very acidic. The stomach wall is much more resistant against the acid, but the esophagus cannot tolerate this acidity and therefore erosion happens. This is painful. It can cause heartburn, which is a burning, painful feeling around the heart and the upper abdomen region. It usually gets worse if you lie down or after eating a big meal. Food can move up the esophagus all the way to your mouth, and this is what we call regurgitation. You will burp, and you will have a salty acid taste in your mouth. This can even make you feel nausea and provoke vomiting. Some people even have difficulty swallowing because of these problems. We call all these symptoms esophageal symptoms because they are all related to the esophagus. But there can interestingly also be extra esophageal symptoms which are not related to the esophagus. These are cough, hoarseness, globus feeling, and difficulty sleeping. These symptoms are bad in itself, but there can even be, unfortunately, worse complications, like aspiration of the stomach content into your lungs, ulcerations, and worst of all, adenocarcinoma, which is a cancer of the esophagus. It takes 5 steps to create a cancer from GERD. The first step is that the walls of the esophagus undergo gastric metaplasia. Metaplasia means that one cell changes to another cell. This means that the esophageal cells change into gastric cells. The second step is that these gastric cells change into intestinal cells. This is called intestinal metaplasia. The third and fourth steps are dysplasia, which means that the cells form a bad shape. So metaplasia is a change from one cell to another cell, and dysplasia is a change in the cell's shape. We can divide dysplasia into 2 types, low grade and high grade, based on how severely the shape of the cells are changed. The last step is when high grade dysplasia forms a cancer called adenocarcinoma. So, how can we diagnose these patients to prevent this from happening? The symptoms themselves are already indication of gastroesophageal reflux disease. But a useful tool called an endoscope can be used. This is a tube with a camera on the tip of the tube that we can insert into the patient's mouth and down through the esophagus until we reach the stomach. Here we can check the gastroesophageal junction. We will use a classification system called Los Angeles classification. Divide patients into 4 groups based on how severely the esophagus is damaged. So, when we look into the esophagus with the endoscope, we will see mucosal folds. These are foldings in the esophageal wall. If we see erosions that are only affecting one mucosal fold, then we can call these grade A or B. The only difference between A and B is that A has less than 5 millimeters erosion, whereas B has more, 5 or more. Grade C and D are affecting mucosal folds that are more than 1. The only difference between C and D is that grade C is less than 75% of the circumference, and D is more than 75% of the circumference. If we suspect that the reflux has caused an adenocarcinoma, we need to take a biopsy of the esophageal wall with the help of the endoscope. When we take a biopsy, we cut out a piece of the wall, and then we look at it under a microscope to see at which step the disease is in. These are the steps that we talked about, namely gastric metaplasia, intestinal metaplasia, low-grade dysplasia, high-grade dysplasia, and adenocarcinoma. Except for endoscopy, there are other methods we can use to diagnose patients with GERD. We can, for example, do a 24-hour pH monitoring of the esophagus. If the pH is acidic, then we know that the stomach acid is being refluxed into the esophagus. How do we measure the pH down in the esophagus? We can either use a tube that we can enter through the nose into the esophagus and place 5 centimeters from the lowest esophageal sphincter, and we can keep it there for 24 hours to measure the pH of the esophagus. Or we can use newer techniques where we put a capsule at this location, which is much more convenient for the patient than to have a tube through the nose for 24 hours. The other benefit of using a capsule is that we can keep it there for longer time. The Bravo capsule can be there for 48 hours, and the OMOM capsule can be there for 92 hours. So, now that we have diagnosed the patient with GERD, we need to treat it. We can use 3 different methods: lifestyle, medications, and operation. When the disease is mild, then lifestyle can be enough. But if there are still a lot of symptoms despite lifestyle changes, then we can use medications. If medications don't work, or the disease is very severe, then an operation can be done. So, what are the lifestyle changes we can do? Weight loss. Don't eat big meals late in the evening. Don't lie down after a meal. Don't eat sweet dishes. Don't drink alcohol. Don't smoke. And sleep with a couple of pillows so that your upper body is a little bit higher up to prevent reflux during the night, which could cause aspirations of food into your lungs. So these are the lifestyle changes that can be used in mild disease. But if these are not enough, and you still have symptoms, then we can take medications. 3 groups of medications are worth remembering: antacids, H2 receptor blockers, and proton pump inhibitors. Antacids and H2 receptor blockers are used in mild disease without any esophagitis, which means without any inflammation of the esophagus. The typical H2 receptor blockers are cimetidine, ranitidine, and famotidine. As you can see, these are all ending in tidine. So, semi, rani, and famotidine. Whenever there are many symptoms and esophagitis, then proton pump inhibitors can be used. The typical proton pump inhibitors are pantoprazole, rabeprazole, omeprazole, lansoprazole, esomeprazole, and dexlansoprazole. As you can see, they're all ending in prazole. So panto, rabe, ome, lanso, eso, and dexlansoprazole. To remember these, let's use a mnemonic called PROLED. P is for pantoprazole, R is for rabeprazole, O is omeprazole, L is lansoprazole, E is esomeprazole, and D is dexlansoprazole. If these medications do not work, or if the disease is severe, then we can do an operation called Nissen fundoplication. This is when we take the fundus part of the stomach and wrap it around the lower esophagus to create an artificial sphincter that increases the pressure and therefore closes the connection between the esophagus and the stomach. Thank you for listening.